I'm doing great, Dr. Srinivas. Thank you for having me on.
I am really eager to kind of learn about how you ended up in West Virginia and the work that you do there.
So I'm trained as a hospital epidemiologist. I'm a practicing adult infectious disease physician. I've been doing healthcare epidemiology and antimicrobial stewardship for about a decade. As many during the pandemic, I realized I was ready for a new challenge. This position opened up at West Virginia University, which is where I am. My mentor in fellowship and my early career, really my whole career, is here, and made the leap about a year ago, and I'm very grateful that I did.
Tell us a little bit more about the setting in which you practice, the context.
Yeah, so West Virginia University medicine. So it's really a health system now of 25 hospitals, over 250 outpatient clinics. We have over 28,000 employees and well over 3 million individual patient encounters per year. So it's a big system. We have hospitals in 4 states: West Virginia, Ohio, Maryland, Pennsylvania. And I have the privilege to work with teams across the system at every single one of our facilities in the work of preventing infections, and also have a role with antimicrobial stewardship as well.
Mhm. And with each university, school of medicine, they each seem to have their own niche based on the populations that they serve. And in West Virginia, it seems like you have a lot of rural populations. Am I right in thinking about it that way?
For sure, for sure. I think many people are aware that West Virginians really disproportionately suffer from a lot of negative health outcomes. There's a lot of poverty. There's poor health access throughout the state, and we, perform sort of really in the lower quartile across a lot of important metrics. And so there's a lot of need here for sure. And so when we talk about the system provides a lot of healthcare access to folks who otherwise would not have it. So when we look at all of our facilities, we have, I think, 11 facilities with 25 beds or less. And so those those are rural facilities, of which 10 of those are critical access hospitals. And so, yes, those are important points at which people can get healthcare and then enter the system. And if they need higher level care, the system also provides that ability to get people the care they need.
And you just brought up a great point in discussing critical access hospitals. And for people who aren't familiar in our audience, could you help define a little bit more about what makes a hospital a CAH and why exactly do they exist?
Yeah, so Dr. Srinivas, it's a wonderful question. I think I'm going to speak in sort of general terms. There's about 1,800 rural hospitals in the U.S. About 1,350 of them, about 75%, have this critical access designation. And this is a designation from the Centers for Medicare and Medicaid Services that essentially allows these institutions to stay financially viable in ways that they may not have been able to stay financially sort of viable otherwise, and also assures that there's some access to care, particularly for rural populations that wouldn't have it otherwise. And I'll speak to, I guess, a couple of the characteristics. They have to have 25 or less beds. Typically, there's some exemptions. They have to be 35 miles away from another hospital. They have to have an average length of stay of less than 96 hours. And they have to provide 24/7 emergency care. And so really they're access hubs, and they get this designation because there's some financial benefits to allow them to stay open.
When we talk about rural hospitals in general, during the pandemic, there were other challenges just within the infrastructure of how they existed. Can you tell us a little bit more about what you saw, especially coming into a new system with 11 hospitals in rural areas, and how that compared to the other 14 hospitals within your system as far as the challenges they faced?
Well, it's interesting. And again, my anecdotes extend beyond my system for sure. But I think your larger facilities and then your smaller facilities, there are pros and cons to the way that they're able to deal with things like pandemic challenges, right? And let's look at the advantages of a smaller facility. Well, one thing I will point out that I have been struck by, and I'm always inspired by, is the commitment of people working at smaller facilities, particularly in rural areas. Oftentimes, they come from the communities, they're fully committed, their actions really are Herculean, and they're able to do amazing things because of that commitment, but then also because of that smaller footprint. They know everybody. They can, turn on a dime in terms of new protocols. If, one day you're not masking, the next day you're masking, they can walk through the whole hospital in an hour, and they know everybody by name, and they can get everybody to do that new protocol very quickly. And so I think that's an advantage. The disadvantage is the infrastructure may not be as robust, right? You may be dealing with a building that was built in the first part, of the last century. You may have a lot of dual occupancy rooms. You may have aging water infrastructure. We are all aware of all the things we had to do during the pandemic to improve ventilation. There are pluses and there are minuses. Dr. Srinivas, can I give an anecdote just around?
Please do.
I had seen over or about a 900 bed academic hospital, really struggle with providing monoclonal antibodies during the sort of the height of when we were giving those when they were active for COVID. Operationalizing that and executing on that sort of plan was very challenging, right? And I was struck when I saw a rural critical access hospital had given almost as many monoclonal antibodies. This is a 25 bed or less hospital as almost a 900 bed academic facility. And I was like, how were you able to do this? And the response was, well, we just had to do it, and so, people rolled up their sleeves. They worked a 14-hour day. They said, Thursdays we would just be here an extra, 9 hours. And they did it because it had to be done and it was serving their communities. And so there's some very special things happening in these environments in terms of just the commitment and just the inspirational sort of nature of how people are approaching this commitment to their communities.
I'm also just amazed that they were able to get the resources in a rural area to be able to deliver care. I mean, on top of the personnel, which is a whole feat in of itself, but to actually get the monoclonal antibodies, that's impressive.
Yeah, I think the other sort of component to things, and again, I'm completely biased here, so take it with a grain of salt. But these system approaches, where we have hospitals coming together to support each other. I think that network really benefits everybody involved, right? I mean, there's lessons learned, there's value for everybody, every facility, but that gives that system also the ability to move critical therapies like monoclonal antibodies when they again worked around in that system to provide equitable access. And so I think that is an advantage.
On the larger scale of things, when looking at actual prevention, did you notice a trend when you would bring in some of these smaller hospitals to be a part of the larger health system? Did you notice any trends in rates of diseases or prevention of diseases that occurred from just having that conglomeration of information sharing?
Well, so caveat is I've only been in this role in this system for a year, right? What I would say is, I did do one of the first things I did was a needs assessment. I went around to all facilities, did site visits, talked to folks, got to know folks, did a gap analysis, and really what I learned was people can learn in a bi-directional way, or I mean, I don't know how many directions 25 directions is, but like everybody learns from everybody else. And some folks are really just doing phenomenal work in one area, Other folks are, really almost a gold standard in another area, and sort of sharing those lessons learned, and then standardizing approaches based on sort of like the optimal performance. There's real value in that. And then also, you have this opportunity to sort of really develop your data for action, get data in a way that folks can use it in the best way possible. And one of the things that we've moved towards is building central repositories of data and data reports. So not every facility is having to do this independently. Everybody can sort of learn in real time from each other. You can compare yourself to others around certain key things, and be able to reach out to those folks to learn about practices, that sort of stuff. And so I think infection prevention, one thing I've learned over the last 12 plus years of doing it, you're always on a journey. And it never ends, right? Because you're always learning some new thing you could be doing, or you're refining what you're looking at and how you feed it back. And I think we're on that journey, as everybody is. And it's exciting to be on that journey.
That's a really unique but optimistic and cool way to look at this evolving nature of the beast in the face of pandemic challenges, and Lord knows what's coming down the line later. But that it's a constant set of knowledge that just needs to be applied in a different way, and that can be utilized with just a little bit of a twist of how we might apply things. So I love that outlook. With all of your gap analysis, what did you find? Did you find any patterns, rather, between what you were seeing in these rural hospitals, things that you might want to adopt yourself in more urban centers, that many people who don't practice in rural settings don't think of?
Well, Dr. Srinivas, I think you realize that there's not a one size fits all for all settings. So for instance, you can look at chlorhexidine bathing, right? And so I'm not, maybe there's somebody who's going to listen to the podcast who doesn't understand necessarily what I'm talking about. So I'll just break it down for one sentence. We know that sort of daily treatment or chlorhexidine bathing will reduce healthcare associated infections, particularly line infections. For people with lines, people in ICUs, people who are 2 months and over, in again in ICUs or with lines, and then we do it more broadly sometimes because it reduces other healthcare associated infections. And we won't go into great detail on all that, but that intervention is going to make a lot of sense in places that have a lot of line utilization, in places with ICUs. And not all of our hospitals have ICUs, and almost never use central lines, right? So some of these smaller hospitals, it's very rare that they're using a central line. Most of their patients are out of that area. They have to be if it's critical access. On average, less than 96 hours a stay, right? So they're either to a higher level of care or they're discharged. And so chlorhexidine bathing across the board in an area where maybe there's higher rates of healthcare associated infections, a bigger facility, that may be the right intervention. But that's not going to be the best resource utilization in a small facility that has no healthcare associated infections, right? So there's not a one size fits all approach to everything, but there's still a desire to standardize. And so how do you strike that balance? That is something I think requires some nuance, some local ability to customize that sort of thing.
With these smaller hospitals where they don't really have the IPC teams or even staff pre-dedicated because there's so much for them to do for the staff that they currently have, how do you work with them to make sure that there's somebody who's able to kind of be the point person to think through this and localize these recommendations while not putting an additional burden on somebody who's already overworked?
Well, Dr. Srinivas, I think you're getting at a really important challenge that I think is facing the field, right? So both healthcare epidemiology largely are going to be physicians sort of leading those programs, but then you have infection preventionists who are really doing the bulk of the work. And the question is, do we have enough of them? And then how are they trained? How do you know that there's a sort of standard way people are approaching things? A lot of folks are just assigned these dearth of ID physicians, right? It's actually a crisis if you, if you truly think about it. And then you also have to say, well, if it's not going to be infectious disease trained physicians, who's going to do it? Again, what is that standard? And we all know at the beginning of the pandemic, everybody seemed to have a PhD in epidemiology, right? Everybody was talking about these high epidemiology concepts, and I think we all sort of know the 2 weeks we got of epidemiology in medical school probably didn't set us up to really speak well to some of these issues, and so we don't really have a standard for physician training. There's some wonderful courses, some offered by the Society for Healthcare Epidemiology of America, that kind of stuff, but there's no standard. There is a standard on the infection preventionist side. They can sit for certification, which is pretty robust, the CIC exam. But again, in many places, they're just assigned the work. And I know one place, again, anecdotes extend beyond my system, where somebody was assigned the infection preventionist role, but had 6 other major administrative roles. And so, is that person going to be equipped to really be the best infection prevention as possible?
Yeah. I mean, and that's such a challenge, especially when we look at some of these smaller hospitals who don't have a health affiliation with the larger hospital that has the resources to have an IPC team. How can they approach this in a way that makes it still reasonable for them to be able to apply some of the IPC edicts? What are some things that they can look to maybe get some information, even though they're not necessarily going to have the hospital epi background that would be most desirable in every hospital?
Yeah, I think the first thing I would say is that infection preventionist, that person who's deemed, hey, you're in charge now of infection prevention facility. It's hard work, and I think that's number one, to say, all right, well, I need to figure out, how am I going to learn this? I need backup. I need a community, and it's really important for that person, if they're isolated, to join some sort of group. One of the primary ones that people end up joining is the Association of Professionals in Infection Control, APIC. Oftentimes they'll have a state branch, and so you'll get a network of contacts, and that's important because everything's going to be new to you, and so you've got a TB exposure in a given clinic. There's a varicella exposure. You're trying to figure out, is this a central line infection? You need a community you can reach out to. But then it also provides you an opportunity to figure out, what do I have to learn to do this the best way possible. The facilities and their leadership also need to recognize, you got to invest in that person. You gotta get them to a place where they're going to be doing the work as best as they can. They're going to feel supported in that, but then also feel like they're doing the work the right way. So those are two things.
So it sounds like APIC is a great resource, and I know some of the people who I work with in rural areas will also say that they can just call up the CDC sometimes and ask questions, and I'm sure that that's not always an easy way to go, but it's, if you're really lost, that's one route. And then you had mentioned Shea earlier. Does Shea have anything that a lot of these rural hospitals, and the person who's going to be in charge of IPC there, is there somebody that they can reach out to, or modules they can learn from?
So SHEA, the Society for Healthcare Epidemiology of America, has wonderful resources. They have training courses, they have online resources. It's a wonderful community, particularly for physician champions of healthcare epidemiology. And I have to say, some of the most active folks in healthcare epi antimicrobial stewardship are not ID doctors by training, right? And so these champions, be a surgeon, a hospitalist, this extends beyond sort of our community. I hate to say that, Dr. Srinivas, because we need more ID docs, but Jay is a wonderful resource for sure. Lots of tools there as well. Going back to APIC, they actually have a tool. It's I think the tool, you can Google this, like APIC, you are not alone. So for that, preventionist who's sitting there, head in their hands right now, just saying, how am I going to approach this? APIC has a toolkit. You are not alone. You can Google it. It's 19 pages, all these great ideas on how do you get started? Where's your, community? How are you going to do this well? That kind of thing.
Oh, that's really, really great. And I mean, you're right. It's not all ID doctors, it's people from all different walks of life. And honestly, that's what we need, unfortunately, because we have such a shortage of ID docs on top of everything else. We can't rely on ID to fill all the gaps, but people also see infection in different ways. A surgeon whose site might have to be worried about OR infections might have a different perspective that they can bring to the table that would be more useful in that setting sometimes. And we always think about rural hospitals, we think about the challenges, and sometimes there's those benefits too that you highlighted. But it's really nice that we're able to have these partnerships now with these alliances. Do you have a hope on what you foresee for the future for many of these rural hospitals and these partnerships that are forming?
I could take it back to the mission and vision of my own organization. I'm not going to try to quote it verbatim, but essential to that and really very moving to me and shaping a lot of the work that we're doing in our system infection prevention program is this idea that the same standard of excellence is available to anyone who touches the system anywhere. So you could come into the flagship academic hospital in a relatively big city, or you could, come into the system at the very smallest facility in the most rural area, and you're going to get that same standard of excellence, that same or that bundle of things to prevent infections that you would get anywhere else in the system. And I think that is the power of these big systems, right? And that's the opportunity to some of these smaller facilities that are entering into these large systems, because now they can leverage some of the power of that size to do things like we've already talked about, which is get access to things like monoclonal antibodies, right? At the height of the pandemic, but then also diagnostics and that kind of thing.
Mhm. And I'm also just even thinking from a resource standpoint, we see a lot of the rural hospitals didn't have access to the proper PPE, but those bulked up a bit when they started to have these larger alliances because they can order from other sources that they're ordering in bulk. So if you were to leave our audience with one key thing that you want them to take away when it comes to IPC, especially in rural areas with lower resources, what would be the thing you want to leave them with?
Well, I would speak to that person just entering the field, just assigned that infection, prevention, this new infection preventionist who, really feels disconnected, doesn't know where to start. I would say you're not alone. Literally, that's the resource from APIC. Google it, look at that resource. It'll help you find your community and folks that you can ask questions to. If you're the physician champion, now being assigned and really don't know where to start, Society for Healthcare Epidemiology of America is a great resource. Get on the website. You can find a lot of good resources there. The last thing I would say is we are seeing more and more of these hospitals come into systems, and really we're at a critical juncture in healthcare in the U.S. Around infection prevention to figure out what are the best system-based approaches to preventing infections. And every network's different, and networks that have a lot of rural hospitals or critical access hospitals probably have to approach things in a different way. And we're just now starting to create those sort of best practices.
Everything comes down to localization, whether it's medicine or food or culture, whatever it is, it's about localizing, right?
You summed that up much better than I did with many fewer words. So thank you.
Not at all. I just always think about food. Well, thank you so much, Dr. Stevens, for joining us today and sharing your expertise. And